Hi everyone, today's tutorial is going to be on an approach to reading ECGs. So there's a lot of information in this, so we'll go ahead with everything, and if it looks like it's taking a second half later. But we'll see how we go, and hopefully we can get through a lot today. So to start off with, we need to understand what it is we're looking at when we're looking at an ECG trace. So this here is what an ECG trace looks like as a kind of diagram form. And what it is basically is we take a patient and we put electrodes on their chest wall and on their hands and feet. And all that we can see from the ECG is when the electricity in the heart comes towards the electrode, we get a positive deflection. And when the electricity goes away from the electrode, we get a negative deflection. And that is all that the ECG is showing us. That is incredibly useful because it tells us lots of information about how the heart's working and what it's doing. And we can also see where in the stage of the cardiac cycle the heart is. So this P wave, we call it, the first bump that happens on the ECG, is showing us that the atria of the heart are contracting. So that's when the atria that we call depolarize, which is the electrical activity that makes the atria contract. Then we have this, which is called the QRS Complex, and this shows us that the ventricles start to contract. And then over here we have the next final bit of the cycle, which is the T wave, which shows us the ventricles repolarizing, which you can effectively think of as the ventricles beginning to relax. So those are the main key components of the ECG, and all that we're seeing is when the atria contract, electricity comes towards the heart to get a positive deflection, and then the ventricles contract, and then the ventricles relax. So it's very straightforward what we're actually looking at. And when we put all the different leads together, we get this. And this is a printout of a real-life ECG, and this is the sort of thing that you'll see in the hospital very often. When you first look at this, it looks a lot like a bunch of just squiggly lines and doesn't really make much sense. And that's why it's very, very important to have an approach whenever you look at anything. Just like we did with chest x-rays, you have a system. With ECGs, you always have a system as well. So, we'll start off by working out what the different lines are showing us. And we can do that by thinking about which bit of the heart each line is looking at. So if you take these sections, you can see on each of the sections of the ECG, there are labels. So if we go back, this is lead 1. So in fact, I'll draw these out. So we've got lead 1, lead 2, and lead 3 here. So you can see that they're all labeled. Here we have leads A, AVL, and AVF. And then these are what we call the chest leads, V1 to 6. So lead V1, V2, V3, 4, 5, and 6. And they each look at different parts of the heart. So leads 1, leads AVL, and leads 5 and 6 are looking at the left side of the heart. So to start off with, we can go into more detail about which bits of which arteries that means it's supplying and the various other details. But just to think about it to begin with, the left side of the heart is being looked at by lead 1, lead AVL. Then leads 2, 3, and AVF. These are looking at the bottom of the heart, the inferior part. So the bottom of the heart is on this section. Leads V1 and V2, this is looking at the front, or the anterior of the heart. And leads V3 and V4 are looking at the septum, so the bit in between the right and the left part of the heart. So overall, we have this picture, which shows left side in red, bottom of the heart in blue, front of the heart in green, and the septal part of the heart in V3 and V4. So that's a simple way of trying to think about what each one of these different funny lines are showing you. Does that make sense to everyone, or are there any questions so far? Good. All right. So, as I said before, having an approach is the key thing to being able to understand an ECG. If you just look at it to start with, it just looks like lots of squiggly lines. So you need to systematically take each part in turn, and that way you don't miss anything, and you know that you've checked for all the important things that could go wrong. So to start with, you make sure it's the correct ECG that you're looking at, so it's the right patient, taken on the right date, because there's lots of pieces of paper with ECGs on them in hospitals, and you don't want to have picked up the wrong one. And you check to make sure that it's calibrated correctly, but all the modern day machines tend to do that automatically anyway, so there's not too much to worry about here. The key bits is this. So this is an 8-step approach. There are 8 things that you do, and it's very, very simple. All we do is we look at the rate of the heart, and we'll take each one of these steps in turns in a minute. So we look at the rate of the heart, we look at the rhythm of the heart, and we look at its axis, and then we just follow the trace. So we do P waves, the PR gap, so the gap between the P waves and the QRS complex, the QRS complex itself, and the ST segment, so the gap between the QRS and the T, and then we look at the T waves, and that's it. So once you've got that system into your mind of rate, rhythm, axis, then P, PR, QRS, ST, T, then you've finished looking at the ECG, and it's all very straightforward after that. So we'll start with the first point, which is the rate. So often on modern ECG traces, the computer prints the rate out at the top of the heart, but it's good to be able to work it out yourself in case that's not available. And the way to think about it is this, all ECG paper is made up of these squares. And there's little squares and there's big squares. Each little square is 0.04 per second, and each big square is 1 second. And what that means is you take 1 point in a cardiac cycle, like the top of the QRS, this peak here, and you find the next point. So that means the heart has gone through 1 cycle between each of these peaks. And you count how many squares it took to go from each peak. So if it takes 1 square, then it's 300 beats per minute, the heart rate. If it's 2 squares, it's taken twice as long, so it's 150 beats a minute. If it's 3 squares, it's 100 beats a minute, and so on. And what you're effectively doing is the rate of the heart can be thought of as, so heart rate equals 300 divided by the number of squares. So heart rate equals 300 divided by the number of squares. Once you get a bit faster, you don't have to keep dividing, making that calculation in your head. You just sort of remember that if there's 3 squares, it's about 100, and so forth. What we're looking at, the heart rate can either be at a normal rate, which is between about 60 or 100, or it can be beating too slowly, which we tend to take at less than 60, so that's what we call bradycardia, or it can be beating too fast, which is a rate of normally over 100, which we call tachycardia. Lots of different things that can cause brady and tachycardias, but we can cover that later. For now, might be able to, when a heart beats less than 60, it's slow. When it's more than 100, it's fast, and to be able to calculate how fast the heart is beating. So if you take the number 300 divided by the number of squares between each of these peaks, you'll get the heart rate. That's all pretty straightforward so far. Any questions about that? Good. So the next step, after we've figured out the rate of the heart, is figuring out what rhythm the heart is in. And there are only really three patterns for the rhythm that you can kind of divide everything else into. So the heart can either be beating with a regular rhythm, can be beating with an irregularly irregular rhythm, or a regularly irregular rhythm. Now that sounds very strange, but it's fine. We'll go through what each of those things mean. So to start off with, this is a regular rhythm. There are basically 2 main regular rhythms you need to know. Can anyone tell me what rhythm this heart trace is in? Feel free to guess if you don't know. Is everyone going to be very shy today? Okay, so I'll give you the first one, but after this you're going to have to start answering questions. So this is what we call sinus rhythm. This is a normal rhythm. You have your, just like we showed before, P wave, followed by QRS complex, and then a T wave, and then another P wave, QRS complex, and a T wave. And they're exactly spaced out by the same distance each time. So if you count the squares, 1, 2, 3, 4, and a little bit, then you've got 1, 2, 3, 4, and a little bit. So they're always identically spaced out. It's a nice regular rhythm. You see the P waves, QRS, and T waves. This is a sinus rhythm, which means that the heart is beating normal. The other regular rhythm is this. Now this is a bit more tricky. Can anybody guess what this is? So ignore the rest of the details, just look at the rhythm of the heart. Can you see anything interesting about the rhythm of the heart? Alright, so in that case, I'm going to give you some options of, hold on a sec. Let's see. So, we'll say, is it sinus rhythm, is it atrial flutter, or is it ventricular tachycardia? Which rhythm are we in? So I've got a few people have answered so far. So there should be a button on your screen. Click which rhythm you want to vote for. I'll give you another 5 seconds to vote. Alright. So, most of you think this is atrial flutter. And you guys would be correct. So, atrial flutter is when, zoom in a bit. If you look at the heart trace, the baseline, you get this funny, what we call sawtooth appearance, and then you have a heartbeat. And then you have these weird sawtooth waves, and then a heartbeat, and then a sawtooth wave, and then a heartbeat. So this is very classic of atrial flutter. And what atrial flutter is you've got in your atria, they should be, you have your sinoatrial node. It should be, you should have irregular depolarizations coming into the heart. So lots of electroactivity, very regular sort of pattern. In atrial flutter, you have a little circuit of just spinning around electricity. So the electricity spins around the atriums at about 300 beats a second. So it just keeps spinning around and spinning around and spinning around. And your AV node, your atrioventricular node, can only conduct electricity at a certain rate. So most of the time that circuit just spins around in the atrium, nothing happens. And then every now and then the AV node lets a beat through. And then it spins around, spins around, spins around, and a beat gets through to the ventricles. So this is atrial flutter, this sawtooth rhythm with a regular depolarization of the heart, and it tends to be in a multiple of 300. So the heart rate will either be 150, or it'll be 100, or it'll be some number divided by 300 divided by a number. But the main thing is really classic sawtooth pattern. This is atrial flutter. So that's it. There are only 2 regular beats, heart rhythms. One is sinus rhythm, which is normal, and one is atrial flutter, which is this, with the sawtooths. What about this heart trace? Can anyone give me any ideas to what you think this might be? I'll give you a clue. So this is an irregular heart trace. And what we mean by irregularly irregular is that there is absolutely no pattern between these beats. So, you see what I mean? These beats are quite close together, then there's a space, then there's a smaller space, then a bit smaller, then a big space, and they're just completely random. There's no pattern at all into how spaced apart each heart rate is. So it's completely irregular. So it's irregularly irregular. And there's only one heart rhythm whenever you see an irregularly irregular trace that you think of. Can anyone tell me what that is? Come on, guys. I'll get it wrong. Name a rhythm that you've heard of. What's an unusual rhythm that you've ever heard of? It's probably the most common irregular rhythm that you're going to see. So if you took this section, this could be a bradycardia where there's less than 60 beats a minute, but that's looking at the rate. But we're looking at the rhythm. So overall, the rate is normal in this heart. It's not a bradycardia. But if you just took this bit in isolation, you could think that. But the rhythm is it any you've ever heard of? All right, I'll let you guys know then. This is atrial flutter. So in atrial flutter, instead of having nice regular rhythms that are coming from the sinoatrial node, which is what's supposed to happen, where you get your little nice P wave, there's just random electrical activity happening in the atrium. And then every now and then a beat gets conducted to the heart. So it's not regular. There's no regular pacemaker. It's just completely irregular beats coming through to the heart. This is atrial fibrillation. So whenever you see an irregular rhythm, you think atrial fibrillation. And that means, what we mean by fibrillation means the atrium of the heart, instead of beating and contracting nicely, are just sort of shaking and vibrating around. And because of that, remember we said before that you said before that you don't have, in your P waves are showing you when the atria are contracting, because here the atria aren't contracting, they're just shaking around randomly. We don't have any P waves. See, there are no P waves coming before the contractions. There's nothing there. And this is atrial fibrillation. This is a really important heart trace that you'll get used to seeing after a while. Just randomly spaced out QRS complexes with no P waves. This is atrial fibrillation. Causes of atrial fibrillation, again, that's something I think we should do another day, but it's good to just have in your head a main kind of differential diagnosis. The causes can be either problems with the heart itself or problems with things outside of the heart. So often if people have ischemic heart disease or they've got problems with their valves, and as they get a bit older, they get a bit of fibrosis and those sort of things, this is the main causes of cardiac causes of atrial fibrillation. Alternatively, if someone's a bit younger, hasn't had many heart problems before, they've had lots of alcohol, and they've come into hospital and their heart's beating in this rhythm, the alcohol has probably switched them into that rhythm, and other things such as having too much thyroid hormone, and occasionally just it can happen without an explanation. We call that low AM. But that's for a later session. Now, is different. This is where there is a regularly irregular beat. And what we mean by regularly irregular is most of the heart cycles, something that's is nice and normal. So if you just took these three beats in isolation, this is a normal QRS, P wave, QRS, P wave, T wave. It's all very normal. It's all regular. And then here, something strange happens. And then it goes back to being normal. And this strange thing that happens keeps happening regularly. So it's an irregularity that occurs regularly. So this is a regularly irregular heartbeat. So you have problem, normal, 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 problem, normal, 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 problem. That's what will happen. And so there are lots of things that cause this. Yes, so Alexa just said this is a secondary heart block, which it is. He's absolutely correct. And we'll come into looking at different types of heart blocks in a minute. But to start off with, I just want you to recognize what we mean by regularly irregular. Has everyone understood that so far? So in summary, when we look at the rhythm section, it's either going to be a regular rhythm, which is sinus or atrial flutter with those sawtooth waves. It's going to be an irregularly irregular rhythm, which is completely random with no P waves, and that's atrial fibrillation. Or it's going to be a regularly irregular rhythm, which will be things like second-degree heart block. Okay, the next thing, after looking at the rhythm and the rate, is to look at the axis. And what do we mean by axis? Now, to understand what an axis is, you have to understand how the heart conducts electricity. When you have a normal heartbeat, the electricity comes into the ventricular node, and then it travels down these conducting fibers, the bundles of His and the Purkinje fibers. And you have different bundles that are divided in the heart. One big bundle goes to the right-hand side of the heart, and this is called the right bundle branch. Then you have a left bundle, which comes across and divides into a left anterior and a left posterior part of the heart. And normally, when all of this is working normally, because you have two bundles here and one bundle here, you have a kind of a direction, an overall direction of the electricity in the heart, which points down in this sort of downwards to the left direction. And that's what a normal axis would look like. And the way we interpret an axis, all you have to do is look at these three leads. Leads 1, 2, and AVF. 1, 2, and 3. These are the three leads that tell us what axis the patient's heart is in. In a normal axis, all of the leads should be positive. And by positive, I mean, if you look at what direction this lead is pointing, this lead is pointing upwards. This lead is pointing upwards with the QRS complexes. They're all positive. There's more stuff above the line on the QRS than there is below the line. And here, even though it's a small QRS, it's still pointing upwards. There's more positive than it is negative. So this is a normal axis. An abnormal axis, you still look at these three leads, and you compare which direction they're all pointing. So now you see this one is still pointing upwards. This now is pointing downwards, so this is negative in 2. And this is also pointing downwards, negative in 3. And all you do is you compare the top with the bottom 2. So the top 1 against the bottom 2. If the top is positive and the bottom 2 are negative, and that gives you left axis deviation. So this is a left axis deviation heart. If in this one we have the top is positive and the the top is negative and the bottom 2 are both positive, this is a right axis deviation. Okay? And that's it. I'll show you a slide here which summarizes that. So, in a normal heart trace, 1 is positive, 2 is positive, and 3 is positive. In left axis deviation, 1 is positive, 2 and 3 are negative. And in a right axis deviation, 1 is negative, and 2 and 3 are positive. So you're always comparing the top 1 against the bottom 2. Everyone got that? It's nice and straightforward. And that means you can immediately axis the heart is in. It's only going to be normal left or right axis deviated. And that just tells you about how these fibers that we mentioned before, how they're conducting their electricity. So these fibers, if you have blocks in conduction in different parts of these fibers, then you'll get deviations in the axis. So if say the right axis is blocked, or the left anterior hemifascicle, or the left posterior fascicle, will give you different axis deviations. And these are all sort of summarized here, but again, you can worry about that afterwards. The first thing is to be able to interpret what the axis is, so you can see that there is an axis problem. Everyone happy? The next stage is just to literally take each ECG component one by one and look through individually. So we'll start with doing that. So the first bit we're going to look at is this. This is the P wave, which, as we said before, is showing you the atrial depolarization, which roughly corresponds to the atrial contraction. There's only a few things that the P waves can do. They can be normal, which we've just seen before, they just look like a bump. They can be absent, so there aren't any P waves. And we mentioned earlier that when there are no P waves and it's irregular, that's atrial fibrillation. Or they can be very tall, what we call peaked. So it happens in right atrial hypertrophy. So when the right atrium has become too big, it means there's lots of pressure that the right atrium is squeezing against, and that makes the muscles get bigger. And that's the right atrium tends to be squeezing against lots of resistance when there's things like pulmonary hypertension or the right stenosis in the valve gets the right ventricle, those sort of things, and can give you right atrial hypertrophy. Or you can have a big, broad, looks like an M, broadened out P wave, and that's what we call P mitrale. So if somebody's got mitral stenosis, for example, so the left atrium is having to contract really hard against a really tight mitral valve, broad and bifid P wave, which is P mitrale. And it happens to correspond that the mitrale is when you're on the, so you have peaked P waves and you have peak pulmonary, when you have pulmonale, so the P peaked corresponds with when it's the right side for the pulmonale, and it looks like an M, with this M shape when it's P mitrale. But again, don't worry about that. It's mainly, are there P waves or are there no P waves, which means AF, and do the P waves look roughly normal, or do they look a bit strange? That's the thing you need to first of all think about when you're looking at P waves. Once we've done P waves, we go and look at the gap between the P wave and the QRS complex. One of two things. It can either be too short a gap or too big a gap. So a normal gap between the P wave and the QRS, so the PR interval, is between 3 to 5 small squares. So if you take this trace, you have your P wave, and then immediately you start your QRS complex. There's hardly any gap at all, so it's far less than 3 small squares. So this PR interval is too short. Zoom in a bit. This PR interval is too short. And that happens when people have things like accessory conduction pathways. So the heart has an extra fiber that's connecting the atrium to the ventricles, so it's conducting too quickly into the ventricle. There's a disease called Wolff-Parkinson-White, yep, that's right, where you have this, what we call a delta wave, where the P wave happens and then there's an upstroke, slurred upstroke, and immediately you have this QRS with a short PR interval, and that's something called Wolff-Parkinson-White. Again, not too much something to worry about when we're starting off, but it's just to be able to recognize that that's too close. Tends to be things like Wolff-Parkinson-White. Alternatively, the gap between the P wave and the QRS can be too long, and that's much, much more common. And in that case, there'll be more than 5 small squares between the atria, between the P wave and the QRS. And that means that the electricity is taking a long time to get from the atria to the ventricles. And as we said, you have those conduction fibers that take electricity from the atria to the ventricles. And what that means is they're conducting too slowly. So if we look at this is an example heart trace. You have your atrial depolarization and a big long gap before you have your QRS. It's more than 5 small squares. Take this one, this is a good example. That's the end of the 5 squares, and then the 5 squares across you have a QRS. So it should be less than 5, and this is a little bit more than 5. So this is what we call first degree heart block. Just means the fibers are working, they're conducting electricity, but they're doing so too slowly. This isn't something necessary to worry about. Lots of people have this when they get older. It just means that their conduction system's a bit slow. This is something a bit different. P wave, then you have a gap, and then you have your QRS. And then you have a P wave, and then a bigger gap, and then your QRS. And then here a P wave with an even bigger gap, and then a QRS, and then finally a P wave with no QRS. It's just been dropped. So you have progressively getting longer, the PR intervals, and then a dropped QRS complex. And then it starts again with a small QRS, slightly bigger PR interval, and then a bigger PR interval, and then you drop your heartbeat again. And as Alexi says, this is something called Mobitz type 1, which is also known as Wenke-Back phenomenon. This can happen in athletes, it can happen in older people as they get a bit older as well, but it's, again, not something that requires any immediate management. It's just an unusual rhythm that can happen that can progress sometimes to becoming something else. But just this by itself is not a rhythm that requires any further treatment. This is called Wenke-Back. The next problem with the PR interval can be, instead of having a progressively longer PR interval, here you have a normal P wave, normal QRS, normal P wave, normal QRS, normal P wave, normal QRS, then suddenly P wave and a dropped heartbeat. And then you have the same pattern repeats over and over again. So this is what we call, again, a regularly irregular. It's regular, and then there's a regular irregularity. And this is type 2. There's another second-degree heart block. So we have first-degree heart block, where there's progressively increasing, a long distance between in the PR interval. Mobitz type 1, which is progressively increasing PR intervals and a dropped heartbeat. And this is Mobitz type 2, where there's normal conduction and then a drop beat. A normal, and a drop beat. And this is a bit more dangerous. This one can sometimes need further management to have things like pacemakers and things put in. But again, it's recognizing this regular irregularity. And the last kind of heart block, you follow this, is a bit tricky. So you have a P wave, and then nothing, and a P wave, and then nothing, then a QRS. It's just completely disconnected. So you have a P wave right next to the QRS, whereas here you've got a P wave with a massive gap between the QRS, and here you've got a P wave with no QRS. So it's completely detached. The atria are depolarizing, and the ventricles are depolarizing totally separately. It means none of the electricity from the atria is getting through to the ventricles. And when that happens, the ventricles have their own kind of backup system. You have your atrioventricular node, which will depolarize by itself, and the ventricles, which will eventually depolarize by themselves. And that protects the heart from, affects the person from dying if, say, in this case, they've got complete detachment. There's no connection between their atria and their ventricles. If that were to happen and they didn't have this backup system, the patient would just die because of heart beating. But this backup system means that the ventricles of the heart will keep contracting even though you disconnected the atria from them. So this is somebody with what we call a complete heart block, or a third-degree heart block. No electricity is getting from the atria to the ventricles, and that's because the atrial depolarization is happening by itself, the ventricle depolarization is happening by itself, so there's no pattern. There's no link between these P waves and these QRSs at all. And that's all the different types of heart block. Does that make sense to everyone? Are there any questions so far about any of that? Good. Axis, P waves, PR interval, and now we've come to the QRS complex. So if you look at this, we've actually already come nearly to the end of our system. So it's very, as long as you have a nice system in your head, it can be very quick to look through these ECGs. So out of 8 steps, we're on step number 6, which is looking at the QRS complex. It can only do a few things, the QRS complex. It can either be too broad, which means that it's more than 3 small squares in width. And the things that cause you to have more than 3 small squares in width is bundle branch block. And like we talked about before, so there are these 2 bundles. There's the right bundle and there's the left bundle that conducts electricity from the atria to the heart. When we mentioned before we had our complete heart block, that was when basically this is all disconnected. There's no electricity getting from here to here. That's complete bundle branch block, which is a third-degree heart block. If, say, you just cut off one of these branches, so the right bundle has been severed, and no electricity is coming through the right bundle, we call that right bundle branch block. And if we cut the other side here, when no electricity is coming in through the left bundle, then we call that left bundle branch block. And you can interpret that on the ECG by looking at leads V1 mainly. So this is a normal heart trace, so don't look for any bundle branch blocks here. This is a normal heart trace. I'm just showing you where it is. So this QRS complex is less than 5 small squares in width. In a bundle branch, it will be broad. And then once you've found a broad QRS, you look at V1. If V1 is negative, so if it's pointing downwards, then that is left bundle branch block. And if V1 is positive, this way, then that is a right bundle branch block. And there's a mnemonic sort of trick to remember that. You can also look at V1 and V6 and say that there's a word William Marrow. When V1 looks like a W, like this, and V6 looks like an M, that's the W and M of William, then there's left bundle. So that's why it spells William. Whereas if V1 is positive and it looks like an M, and V6 is negative and it looks like a W, then this is right bundle branch block, so we have an R. So this looks like Marrow. So it's either William or Marrow, but the main thing to look at is whether V1 is positive or negative. So let's try doing that. So here, we'll look at our QRS segments, and they're far too broad. Remember we mentioned earlier that your QRS should be less than 5 small squares. Well, this is nearly 10, isn't it? Because I've got 5 here and 5 here. This is a very, very broad QRS. So once you see a broad QRS, you come and look at V1, like I said. And we can do both of them together just a second. Zoom out. So, can anyone tell me, let's do a poll. Is this right bundle branch block, or is it left bundle branch block? Oh, it's about 50-50 people are voting so far. Still got a few people to vote. Give you another 10 seconds to vote on your choice. Okay. So, most of you thought this is left bundle branch block. And the answer is left bundle branch block. So you're all absolutely correct. And the way that we work this out, like we said before, V1, it looks like a W, it's pointing downwards, versus V2, looks like an M, it's pointing upwards, sorry, V6 is pointing upwards, and this is our left bundle, it's William. Or a better way to think about it is that V1 is negative. And V1 is pointing down, it's left bundle. How about this one? Is it right bundle or is it left bundle? Yeah, that's too easy for you because you knew I was going to put a right bundle after a left bundle. But the main thing is, you need to be able to recognize again. So V1 this time is positive. V1 is pointing upwards. It's positive. Or it spells marrow. We've got our M here. And here is our W. It's pointing downwards. So we've got right bundle branch block there. And that's it. So, main thing, you see a QRS complex that is too broad, more than 5 small squares. So you see that's really broad. It's more than 5 small squares. And then it's either going to be left or right bundle. And then as you go to V1 and V6 and you work out it's left and right bundle. Exactly. And using the mnemonic means that you never forget which way around it goes. So the M of marrow means V1 is positive. The W of William means V1 is negative. Is everyone happy with that before we move on to this? Any questions? All right. Now this is another kind of broad complex. So here, like we said before, you've got QRS complexes, which are a lot broader than 5 small squares. See, that's really big QRS complex. And the other thing is they all look, there's nothing else going. There's no P waves, and it's just exactly regular, all identical, perfectly identical, broad complex. And also, what's the other thing? How fast is this rate going? Can anyone tell me the rate of this heart? I'll zoom in a bit to make it a bit easier for you. So, how fast is this heart beating? If it is beating. How fast are these QRS complexes happening? So remember, you take 300 divided by the number of big squares between these. Yeah, it's almost 300 beats a minute, so no heart can beat at 300 beats a minute. So this is called ventricular tachycardia. And you can see, if you read what happened to this person, he had a heart attack, and then he became cold, clammy, lost consciousness, and his blood pressure was unrecordable. So this is somebody who's had ventricular tachycardia. And that is this is something you can just look at the ECG. You don't have to have it, even without a system. You can just see this straight away. This looks really strange. A broad, complex, regular tachycardia is ventricular tachycardia. And that's often, if the patient's heart isn't beating, it can go into this. Sometimes people can have a heart beating at with this sort of tachycardia, but often it can be somebody who's had a cardiac arrest, so their heart has stopped beating because it's far too quick, the electricity that's going through it. It's good to just be able to recognize this broad, complex tachycardia is. And so this is just to recap. So the right and the left bundle branches that we talked about. There are again various causes. It's something we can think about in later tutorials, but for now it's just recognizing the right and the left. So left bundle tends to be much more of a problem. So if somebody's got chest pain and then they developed a new onset left bundle branch block, that means they've probably had a very, very big heart attack, and you treat them as if they've had a big heart attack. Whereas in other people, if somebody's asymptomatic and you just pick up a young, healthy, fit person with a right bundle branch block, that can be normal. It can also happen in atrial septal defects or in pulmonary embolisms, but the causes are things we can worry about later. First of all, we need to be able to recognize which kind of block we're looking at. So that's what happens when the QRS complex is too broad. The other thing that the QRS complex can do is it can be too tall. And that just means that there's a lot of electricity going through a big mass in the heart. So the heart has become hypertrophied, or the muscles have gotten bigger. And there are two types of hypertrophy. Either we can have a left ventricular hypertrophy. So what we do is we take the chest leads. These will be 1 to 6. So this is like, if you remember, this is on the far edge of the ECG trace, these chest leads. And we can look at how big the QRS, how tall it is from top to bottom. And we can add up the number of squares that make up that height. And what you do is you take leads, either V5 and 6, and you add up the number of squares. So this one has got 1, 2, 3, 4, 5, 6, plus 7, 8, 9. So there are 10 big squares that make up the height of the QRS in V1 and V6. And if it's more than 7 large squares, then that is left ventricular hypertrophy. There are various other ways to do it, but that's just a nice, quick, simple way to think about it. If this plus this is more than 7, then it's left ventricular hypertrophy. Alternatively, you can have right ventricular hypertrophy. And remember we said that which sides of the heart we're looking at. So up here, this is on the front of the heart, but the front of the heart is the right ventricle. So if you look at the way the heart sits in the chest wall, the right side sort of sits anteriorly on the front. So here we have a big positive wave in V1. It's not broad like it was in the right bundle branch block, but here it's just really positive. And that often happens in right ventricular hypertrophy. You also get lots of other things, like you have your right axis deviation. So you can see this patient who's got negative here, positive here, positive here. So he's right axis deviated. Got a on. You have something called strain patterns and things, but that's a bit more advanced. We don't need to worry about that for now. But this is the main thing, that in right ventricular hypertrophy, you can get a positive V1 with right axis deviation. But in left ventricular hypertrophy, you have very tall waves, QRS waves in the chest leads. Good. So QRS complex can be too broad, underbranch block, too tall, hypertrophy, or you can have abnormal Q waves. So let's look at what that looks like. So remember we took the cardiac cycle and we looked at what each different part of the wave showed us. You have your P wave, Q, which is this bit, and you have R, which is this bit, and then you have S, which is this bit, before you have your T. So that's why it's a P, Q, R, S, T. In a normal person, you have a little bit of Q waves that come, so it's small Q waves, less than 2 small squares that just point down a little bit in the start of the QRS complex. That's normal. In abnormal Q waves, you have these huge drops. See this? It's what we call dagger Q waves. Very deep drops. Compare that with the side on the other side that's put them together. So if you compare Q waves here, tiny little ones, versus these massive Q waves, more than 2 small squares. These are pathological Q waves. And this tells us if a patient's asymptomatic and hasn't got any problems, and you've just seen this on an ECG that you've done routinely, it means they've had an infarct, a heart attack in the past, which is now resolved. So they've had a heart attack, a bit of their heart tissue is dead, and this is leftover dead tissue is showing you these QRS, these deep Q waves. If you see these in combination with ST elevation that we'll see later, then that means they're having an acute big heart attack. But if it's just by itself in somebody who's asymptomatic, it means they've had an old heart attack. And that's it for the QRS complex. So it's either too big, too wide, too tall, or has abnormal Q waves. Does that all make sense so far? Are there any questions? Alright, so now we're going to get to one of the fun bits. So this bit is the ST segments. And these are where you'll make your diagnoses a lot of the time if somebody's having a heart attack or they need immediate management if you're in the accident and emergency part of the hospital, or if somebody on the ward has developed chest pain and you need to know if they're having a heart attack or not. This is the key part to look at. And the ST segment can only do 2 things. It can be elevated, so it can be too high, or it can be depressed, so it can be too low. And we'll look at what that looks like here. So remember this picture where we talked about the different sections of the heart? You can do 2 things when you look at the ST segments. If you do see them that are elevated or depressed, you can say that most of the time that's going to be because the heart is ischemic, so they're not getting enough blood supply to that part of the heart. And you can also work out which part of the heart isn't getting enough blood supply by looking at which part has got the elevated ST segments. So this is a nice trial run. So let's try and use our system that we've just worked out. So I want somebody to, what I'm going to do, let's see. So we're going to run through our whole system from start to finish, and you're all going to make a diagnosis of what's wrong with this patient. So this is a 50-year-old man who came to the A&E department with chest pain. He's had it for the last sort of hour and a bit. And it's a central crushing chest pain that's radiating into his jaw and down his left arm, and he feels short of breath and a bit sick with it, and he looks very sweaty and clammy when you examine him. So let's start. What's the first step that we're going to do? So somebody type to me, what's the first step that we'll look at on the ECG trace? Okay, so you're all not gonna answer. Fine, we're gonna have to do it a different way then. So, step 1 is the rate. We look at the rate. So this patient's rate is okay, I'll put up a poll. Is the rate What's this patient's heart rate? So the important thing is not to don't jump into making an immediate diagnosis. Like we always take the ECG and we work through from the system. So if somebody hands you an ECG, you can't just say, this is this disease or this is this disease. You say, okay, I've got an ECG and I will do my system. I'll look at the rate, rhythm, axis, P waves, PR interval, QRS, ST segments, and eventually T waves. And that's it. You always start with that. So we've got some answers. So people are saying these things. Yeah. So it's, again, let's add them up. So we've got 1, 2, 3, 4, 5. So we've got about 5 squares, big squares between each QRS. It's around between 75 to 60. So that's about 60 beats a minute. This one's about 4 and a bit. So it's roughly somewhere between 60 to 70. Is this regular or irregular or regularly irregular? And can you see P waves? So let's say, can we see any P waves here? Are there any P waves? Okay. So most of you think there are P waves, and yep, you're absolutely right, there are P waves. So you zoom in a bit. Let's take a look at some P waves. So if you look here, P wave before the QRS, P wave before the QRS, P wave before the QRS. There's lots of P waves, so there are definitely P waves. And the heart rate is pretty regular. So it's roughly, the gap between here to here is pretty much the same as the gap between here to here, the gap between here to here, it's pretty close. So this is in sinus rhythm. So, we know he's in sinus rhythm. What is his axis? Is it normal? Is it right axis deviated? Or is it left axis deviated? So everyone's voting different things. Okay. A couple more seconds to vote if you haven't voted already. So, most of you thought this was normal axis, and you're right. The way we work it out, 1 is positive, and looking at 2 and 3, this is 2 is positive, and 3 maybe a little bit negative, but it doesn't matter. It has to be this 1 is positive and 2 and 3 negative, or 2 and 3 positive and 1 is negative. They have to match. So unless you get patterns, then it's a normal axis. So yeah, they're pretty close to. This isn't hugely negative, but it doesn't matter. It has to be this is different from these two. So it isn't a case that this is positive and these two are negative, or that these two are negative and this is positive. Therefore, it's not a right or a left axis deviation. So axis is normal. So rate, rhythm, axis. P waves. We've said we can see the P waves already, and they're pretty normal. PR interval. So let's zoom in a bit on one of them. Let's take the top one. Is it between 3 to 5 small squares? Yeah, it's about 3 small squares there. It's fine. There's nothing exciting about the P waves. See that? About 3 to 5 small squares. PR interval's fine. QRS segments. So, is the QRS broad or normal? QRS segments, they're broad or normal? So most of you think that they're normal, and you're right. So a broad QRS has to be more than 5 small squares, and this is definitely not more than 5 small squares, this QRS segment. This is not 5 small squares. Are they too tall, or are they normal? So are the QRSs tall or normal? So they are normal, that's true. So this bit, if you add up the height on V6, add up the height of V6 and you add that to V2, this is about maybe 3, maybe this is 4, this is about 1, so 1 plus 3 is 4. Have any hypertrophy. V1 is negative, so it's not right ventricular hypertrophy either, and we don't have right bundle. So there's no hypertrophy here. So far we've seen that this patient's got a heart rate of 60 beats per minute, with a sinus rhythm, with a normal axis, no ventricular hypertrophy, no bundle branch block. So the last bit of the Q waves, of the QRS complex is, are there any Q waves? So are there any pathological Q waves? Or are there no Q waves? Oh, it's about 50-50. So half of you think there are none, and half of you think there are. Let's see if we can solve the debate. So let's look here. The first deflection down, remember our QRS, we've got our P, Q, R, S, and then our T wave. So look here, the first deflection down is our Q. So we've got, so you got here, so P, Q, really deep dagger Q waves in our ST segments. You see that? Deep dagger Q waves. You compare that, and you've got the same thing up here. Big Q waves before we have any QRST segments. Big Q waves, big Q waves. There aren't any Q waves here. There aren't any Q waves here. There aren't any here. But we definitely have some big ones here. Confusing thing about this is where the transition point happens between VR and lead V1 and VL and V2. It's just how it's been printed out on the screen on the machine when it prints them out. But you can see there are definitely Q waves. Fine. So that's one thing. We found some Q waves. We can see them in V1, V2, V3. You can see them in V4. Can't really see any in V5. Can't really see any in V6. So there's nothing doing this deep dagger Q wave here. So we've got Q waves in V1, 2, 3, and 4. So which areas are those? Which parts of the heart are? So is it the inferior parts? The anterior parts? Or the left part? Where are we finding these Q waves? Good. So most of you thought it's in the anterior septal. Well remembered. So remember V1 and V2 is looking at the anterior part of the heart. So you've got Q waves in the anterior part. And V3 and V4 are looking at the septal part of the heart. We've got Q waves in the anterior septal part of the heart. So that's interesting. That either means this person's had an old heart attack, which has affected their anterior septal part of their heart, or they're having a current heart attack that's affecting their anterior septal part of the heart. And how are we going to decide if that happens? So we've done our QRS complex. Now we're going to come to the ST segments. And this is where the fun happens. So let's pick here to start with. You can see this is what we call the isoelectric line. This sort of the kind of level that the heart trace is sitting at. You can mark it from this. This is the the marker voltage. This is just the kind of calibration voltage that the machine makes. This is produced by the machine before it starts the trace. And you can see that its 0 point is around here. So this is where it's saying is 0. If you follow that through, the ST segments here, pretty much at 0. There's not a huge gap. Maybe there's a tiny bit of depression there, but if you take here, that's pretty much at 0. So ST depression in this part of the heart, along V1, V2. Let's look down to V3 and V4. So V1 and AVL are looking at the left. They're both pretty normal ST segments. V3, AVF, and V2 are looking at the inferior part. Again, no huge ST elevation. It's all looking pretty normal. So let's look over to the other side of the heart. Let's look around here. Okay. We looked at the left part before. Again, these are all pretty stable, the ST segments. What about here? So let's take our isoelectric line. And you see, you have this. There's definitely ST segment elevation coming above the lines on all of these sections. Can everyone see that very clearly? So now, we've got ST segment elevation on V1 to V4, which is the same segments that we said before we had Q waves on, and that's the anteroceptor part of the heart. So this patient has ST segment elevation and Q waves on the anteroceptor part of their heart with severe chest pain. And can anyone tell me what the diagnosis is for this patient? I'll give you two options. Is this really bad, or is this not too bad? How sick is this person? Do you have to worry about this person if you saw him in A&E, or is it something you can kind of leave alone? So you've got to decide, you're in A&E, is this a sick patient that you can kind of, is this a sick patient you have to immediately drop what you're doing, this is an emergency that has to be sorted out now, or is this somebody that you can leave alone, go and have lunch, come back and sort out later? So yeah, this is really bad. This is a segment elevation myocardial infarction of the anteroceptal part of the heart. So this is an acute anterior myocardial heart attack, basically. This is a very, very big heart attack. Whenever you see ST segment elevation, what that's telling you is this is a full thickness heart attack. The heart tissue, the muscle of the heart, has died, is infarcting the whole length of the way through the heart. So there's a big hole that is just dead tissue now, all the way through the heart, because that's what these ST segments are showing you. So this is a really sick person who needs to have immediate heart attack management. He's having a very big heart attack. Anterior myocardial infarction. Alright, what about this one? We'll do this one a bit quicker. So I'll run one victim. It's a 50-year-old man who's come to the emergency department. So yeah, so the minor effect that Alexis just mentioned on that previous ECG in leads 2, 3, and AVF. So let's see, what are we looking at? Zoom in a bit. You can sometimes get something called reciprocal change, which means that when you have ST segment elevation in these leads, you can have ST segment depression in opposite leads. And the reason that happens, so the ST segments might be a bit low. The reason that happens is that remember we talked about where the leads are looking? They're looking at different, so the same pathology being looked at a different angle. And that's why you get different pictures. We'll actually see a much nicer example of that in a minute. But let's go back. So that is, you can see some other problems, but the ST segment elevation is the bit that should be telling you where the pathology is. Let's look at this one. This actually shows a nice example of what you just mentioned. So the reciprocal change that we're talking about. So we've done, this person's got chest pain. Come into the emergency department, you do this ECG trace. We look at his rate, and we say it's between, so it's 1, 2, 3, 4, it's about 75 beats a minute, his heart rate. His rhythm, pretty regular. It's the same space between each point. They're all pretty regular. Then there are P waves. You can see a P wave here. You can see a P wave here. Another P wave there. So there's P wave. So he's in sinus rhythm. It's 60 beats a minute, 75 beats a minute. Regular sinus rhythm. Axis. Positive. 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 So he's got a normal axis. P waves. We already mentioned they're there. They look normal. QRS segments. 1, 2, 3, 4, 5, 6. So they're quite big, these sections actually, but they're not quite meeting voltage criteria. So if you add this up, 1, 2, 3, 4, 5, 6, it doesn't quite make 7. So he's not quite got left ventricular hypertrophy. So they're not too tall. Are they too broad? Well, that's less than 5 small squares. That line is 5 small squares that I've just drawn, and that QRS is definitely less than that, so they're not broad QRSs. Are there Q waves anywhere? Possibly. They're a bit small, they're a bit hard to see, but there might be some Q waves there actually. But let's skip and go to the ST segments. I'm going to give you some options. Is there, first of all, if there's a problem with the ST segment, is it in the inferior part of the heart? Is it in the anterior, or is it in the lateral part of the heart? So where is the problem in this patient's heart? So 10 more seconds to... So mostly think it's in the inferior part of the heart. And you're right. So let's look at a bit closely at the inferior segments. Here. So we said the inferior part of the heart is leads V, F, 2 and 3. That's our inferior segment. And you can see if we take our isoelectric line, P wave, QRS, ST segment, elevated. ST segment is elevated. And the same here, isoelectric line, elevated ST segments. So this person has got ST elevation in leads 2, 3, and AVF. Now, just picking up on the point that Alexi mentioned earlier about the changes in other leads, you can get a bit of reciprocal change. So if you look here in the lateral leads, for example, or the anterior leads, look at V2. That's our isoelectric line. There's a bit of depression. The ST segments are depressed. And same here in V3, a little bit of depression. And this is what we're seeing is the same ST elevation, just looking at it from behind, so it looks like a depression. But the elevation is what you should be focusing on. So this person is having chest pain, ST segment elevation in the inferior leads, so he is having an acute inferior myocardial infarct. So good, you've made all the diagnoses. We'll skip through, as I said before, you should always do your system, but now we're looking at the ST segments. Let's skip right to the ST segments. Can anyone see what the problem with this patient's ST segments are? So is it in the inferior, lateral, or anterior part of the heart? Five more seconds to vote. Okay, so 75% thought it was the anterior, 1% thought it was inferior. So let's look at how wide this is an anterior lateral myocardial infarct. So if you look at the inferior sections, people who said it was inferior, it's the isoelectric line, following it through. Oops. There isn't really any ST segment elevation. It's not really, might be a bit depressed slightly. But if you look over here on these sections, so our isoelectric line, here's our isoelectric line, look at this. That is a huge ST segment elevation there. Same thing again here. So, and if we look at our lateral lead, so we've got more ST elevation here. If we look across to, say, V1, this is our V1 segment. You can see again, this is the anterior, this is the isoelectric line, and we've got some ST segment elevation in V1 as well. So that comes above the line. This is an anterior lateral myocardial infarct. So we're coming pretty much to the end now. One last thing to look at and then we're done, which is just the T waves, and that actually we saw a lot of time in our previous, those two slides that we just looked at with the heart attacks. So T waves should always be pointing upwards, like a nice normal T wave. If you get an inverted T wave, that can mean a few things, but it tends to mean ischemia. So it tends to mean happening in things like a heart attack or not enough blood getting to the heart. The other thing that you might see is you can get quite tented T waves. So instead of it being a nice sort of small ordinary T wave, you get these really big T waves, and we'll see both of those in a second, and then we saw this slide already. This was our anterior heart attack. Sorry, our anterior heart attack. So lots of ST segment elevation. But if you look also at the T waves, these T waves are upside down. So we've got the full house. So this is a normal T wave here. Look at V3, that's a normal T wave pointing upwards. Here, that's an upside down T wave. So we've got a full house of Q waves, ST segment elevation, and inverted T waves. That very classic of having an ST segment elevation heart attack, myocardial infarct. The other thing that you can see with the T waves is this. So this looks really crazy. This is somebody who's got lots and lots of potassium, so hyperkalemia. Their potassium levels are really high, and that means that the heart is very susceptible to having arrhythmias and getting lots of very dangerous and can be fatal, especially at this level where you're getting these ECG changes. You see the T waves are huge, massively peaked, tall, tented T waves, and also it's starting to become what we call sinusoidal. It looks a bit like a sine wave. It just looks like a long, slow sine wave like this. Because it's being stretched out and very broad with these peak tented T waves. And that happens in hyperkalemia. But again, that's something that is a bit more for a detail. So we've done everything now. That's our full approach as a kind of rough run through of how you look at an ECG. You start off with the rate, rhythm, and axis. Then you look at the P waves, PR interval, QRS segments, ST segments, and T waves. There's only a few things that can happen with each of those, and you make sure you in your head have sort of a checkbox of, is the ST segment elevated? Is it depressed? Are the QRS complexes, are they too tall? Are they too broad? Are they abnormal Q waves? And you do that for each one of your different steps, and that means you'll always be able to pick up. But there is a problem, even if you're not necessarily sure what that problem is, and you'll also be able to work out where in the heart that problem is by the territories that we've talked about. And that's it. Any questions about any of that? Anything you want us to go back over and look at? Or any other concerns that you have about ECGs, our initial introduction to ECGs? Excellent. Good. Well, I'm glad you all enjoyed it. I hope you found it useful. We'll let you know about when we're going to do our next tutorials on the website soon. And if you have any other questions, just let me know. But other than that, thank you very much, and we hope to see you all soon.